trials, and now we're getting into evidence-based medicine. And what does that mean? Non-randomized control trials, all of these showed that it could, whatever it was, decrease cesarean section rate. A randomized trial supported that. Then Thornton and Littlefield, Jim Thornton is a very good friend of mine, and we talk about it regularly. Delivery units should endeavour to produce continuous professional support in labour, but routine use of amniotomy and early oxytocin is not recommended. I mean, of course it wouldn't. It's not amniotomy and oxytocin, it's a whole package deal. 3 more randomised controlled trials came out. Frigoletto showed no difference in cesarean sections because cesarean section was the big issue now. And Camus from Belgium. Camus from Belgium had a very low cesarean section rate anyway. I'm not surprised. I would be surprised if anything changed their section rate. Frigoletto, well, that's we'll come back to that in a minute, but that was a large trial and it showed no difference, but importantly, it showed no harm otherwise, and there were other benefits to it. Jim Thornton came out again, routine active management labour will disappear. And we still don't know what active management it means. It's small a, small m, big A, big M. But there remains much work to put labour management on a reliable evidence base. We would all agree with that. Some people went further. The active mismanagement of labour. We're all working together to one end, some with knowledge in design and others without knowing what they do. Interesting, isn't it? Conclusions, you know, whenever we're stuck, we do a meta-analysis. So this was a meta-analysis. Active management labour reduced the duration of the first stage of labour without affecting the rate of cesarean section, maternal satisfaction or other maternal newborn morbidity. And that's probably the fairest reflection. And then the Cochrane review. The initial Cochrane review said that there was no difference in the cesarean section rate. Then they redid it and did it, and they showed here that duration of labour was reduced, and that was the principal purpose of active management labour. The duration of labour greater than 12 hours, prolonged labour was reduced, yes, and duration of labour longer than 12 hours was also reduced. And cesarean section rate, all women, showed that, again, there was no difference in cesarean section. But then there are some very clever people around, and when they looked at the Frigoletto study, and this is the up-to-date Cochrane database, they showed that there were issues with the randomization of that trial, and it should be excluded. And surprisingly enough, their conclusions after this, active management labour is associated with small reduction in the cesarean section rate, but it is highly prescriptive interventional. Very interesting. It's very interventional, but it reduces the cesarean section rate. So, you know, then there's different levels of intervention. It is possible that some components of the active management labour are more effective than others, and again, further work. But that's when I come back to, isn't evidence-based medicine really personal opinion based on fact? There's so many examples of that. I don't think it's a problem, but we should have insight. We all know, the senior people all know in most situations what's right or wrong. Our problem proving it. Fortunately, there's an RCT supporting our opinion. If we don't find it, we look everywhere in the literature to see if we can find one. And if not, we go back and criticise the original RCTs, showing why they were done so badly, or look for some other point of view. And insight is not a problem. That's true. The Breach trial, for example, I mean, is a perfect example of that. The other way of looking at things, and I think there are other advantages of this, is this 10-group business, the classifying cesarean sections, which is not only cesarean sections, but every intervention. And what it actually does show, what is going to be the issue about the cesarean section is your section rate in spontaneous nullops and your ratio of spontaneous to induced labour in group 1. The single cephalic nullop is going to be the most written about group of women in times because it drives everything else. Once you've got a cesarean section, forget your breaches, forget your previous scars, forget all of that. They're not a big contributor. Now, I haven't got time to go through that, and I know I'm keeping you from your coffee, but I'll try and finish as quickly as possible. But this was a paper that we published recently showing comparisons of international cesarean section delivery rates and showing the difference in cesarean section rates in spontaneous labour. This is group 1, spontaneous single cephalic nullops. This is the size of the group within the population, 30%. It's a significant group. And this is the variation in cesarean section rates. 23%, Toronto or Auckland, they're probably not in labour. There's some other issue. But that is going to be the reflection. And the last one is the contribution to the overall section rate. And remember, it's not only that time, but it's the next one. And this is the global survey, and the cesarean section, the one in South America. So the future, the name. Active management of labour. What does it mean? What good has it done? It's very catchy. Everybody remembers it. But I would suggest to you very few people know actually what it means. I'm not quite sure myself sometimes. But it isn't what you do. It's a process. It's a active involvement, active interest in labour would be a far better term. And I think, you know, the term has caused problems, and even just before O'Driscoll died, when we did sadly died a few years ago for this, and even then he was thinking about the name and can we change it, but we can't change it. The name is what it is. But interestingly, though, has any of you seen this book, Proactive Support of Labour? That's a lovely name, isn't it? But you read it and tell me the difference between that and active management of labour. It's a very popular book in Dutch. Originally the publication was in Dutch. We don't know these people either. They just read some articles and things like that. And I think one of them visited the hospital. But the original one was in Dutch, and now there's an English one. And it's got a lot of references and puts, if you like, active management of labour on a more kind of thing. I think these are things going to make the difference. Making normal birth a reality and joint policy statement of normal childbirth to define what is normal birth, what's normal delivery, what is a physiological birth. Really, not what's natural or artificial, what's normal or abnormal, but what's good and what's bad. And it can only be taken further by good results, recording the results and learning from each other, because I think we may be on different extremes of a circle, and I think that, you know, we have a lot to learn from each other, but we have to develop a common language for appreciating that. And this is what it's going to be, something like desired outcomes. We assess our management, evidence-based management, and order and classification of information. And this is what I like seeing, is midwives, doctors interacting, arguing, discussing, debriefing forms, talking amongst themselves, and I think that is the future. That doesn't mean to say I have to see every patient or the other way around, but it does mean that we have such a relationship that it's very much easier to talk to each other. And I think in the future, informed choice will lead to 3 types of care. Some will have a birth plan of minimal intervention and they don't mind what will happen, and we may agree or disagree with that. Some will request elective caesarean section, and we may or may not agree with that either. Others will prefer short labour, one-to-one care with a high chance of vaginal delivery. And remember, prolonged labour or time on the labour ward is, whether we like it or not, related to the opportunity to provide one-to-one care. Because however many midwives we have in the future, there's got to be. We've got to show that whatever type of care shouldn't be to satisfy short-term gains, and that we should be able to provide one-to-one care. But everything we do is to try and provide one-to-one care. Others will prefer short labour, one-to-one care with a high chance of vaginal delivery. They will be choosing whatever this thing called active management labour is. And lastly, active management labour and evidence-based medicine, I'll leave it to you to decide. But in providing quality of care to our patients, we have a responsibility to practice evidence-based medicine. But let us not forget our responsibility to collect the evidence to ensure that we are providing quality of care. Thank you very much.